Good morning, everybody. It's a great pleasure to be back with you again to talk about a very important topic, and that is endometriosis and infertility, and then, of course, the role of in vitro fertilization. This is a very, very broad topic because endometriosis is a condition that occurs in probably around 10 to 15% of all women in the general population. In women who have infertility, the endometriosis may be present in as many as half of them. And in women who have unexplained IVF failures or unexplained infertility, it can be as high as 70%, especially if there's associated chronic pelvic pain. So this is an extremely common condition. There have been significant breakthroughs in the diagnosis of endometriosis. But before we get to the actual management of patients with this condition, there are a few things I'd like to say. First is that endometriosis is a condition where the lining of the uterus, the endometrium, grows outside of the uterine cavity in the pelvic arena and in the abdomen. It can also, on very rare occasions, be transported via the blood system to remote areas such as the lungs, the bone, the brain, and various other distant portions of the body. But it's almost always confined, in the vast majority of cases, to the pelvic region. In order to understand what endometriosis is, let me explain that the endometrium, or the lining of the uterus, is shed every month with menstruation. 2/3 of the lining, that is passed vaginally. But don't for 1 minute believe that all the bleeding that occurs is vaginal. In fact, the blood can track backwards through the fallopian tubes, spill out of the ends of the tubes that hang over the ovaries like shower heads, and it can attach to the ovaries and spill into the pelvic content. In the pelvis, there are secretions, and these secretions pass through a thin membrane that envelops all the pelvic organs, known as the peritoneum, which is porous. The secretions are there to help the organs slide over one another and not gain attachment and cause scarring and adhesions. It's a lubricant. And when the blood spills out of the ends of the fallopian tubes and gets into the secretions of the pelvis, it tends to attach to this peritoneal membrane, forming little islets or collections of endometrial tissue that grow and proliferate under the effect of estrogen in all women and in all cycles. May I point out that most women will experience in many of their menstrual cycles, if at least one fallopian tube is open, will experience the spillage of blood into the peritoneal cavity. And this blood, of course, contains live endometrial cells emanating from the shed endometrium that takes place during the menstrual cycle, during menstruation. Yes, indeed, most of the blood does pass vaginally, but some very commonly passes via the tube into the pelvic cavity, and then these cells attach to the peritoneal membrane all over. Under the effect of estrogen, these cells, as I said, multiply. You won't see that in the pelvis in the vast majority of cases because the deposits are translucent. They're not visible under normal circumstances. Microscopically, they can be seen, but they're not visible. That is in this condition where women, and I say again, most women, will have these deposits grow in the pelvis. Because the definition of endometriosis is the growth of endometrium outside of the pelvis, we call this physiological occurrence of deposits a paraphysiological event. And then what happens in the middle of the month, when the woman ovulates, is she starts to release progesterone hormone. This signals the immune system to send cells through the pores of the peritoneal membrane into the pelvis to engulf and destroy and remove these endometrial deposits. It functions almost like that old-fashioned game that most of us, or most of you, not me, are too young to remember, called Pac-Man. It kind of gobbles up all the deposits, and by the time the period comes, the endometrial deposits are gone. These paraphysiological endometriosis deposits are gone. And then the process starts all over again. Now, one of the common theories as to how endometriosis develops is that for some reason, some women have a slight depression or suppression of this clearance mechanism, which is immunologic. And in the process, some of these deposits remain behind. And then month after month, after year, they grow and pile up, so that eventually there's so much endometrial deposit that when the woman menstruates, she bleeds also into these endometrial deposits on the surface of the peritoneum, most commonly on the ovary and at the back of the uterus in the sump of the pelvis, called the cul-de-sac, on the peritoneum there. But it can occur anywhere in the abdominal cavity or pelvis. And then these deposits bleed, and now the bleeding stops after menstruation ceases, and then the blood starts to absorb from these deposits where bleeding has occurred. Now, blood contains red stuff called hemoglobin, carrying the oxygen. And this hemoglobin is primarily an iron compound. So upon absorption of the blood out of these deposits, the iron compound leaves a telltale sign of a pigment called hemosiderin, which is an iron pigment behind. This has the appearance of little gunpowder burns all over the pelvis, and it also can look, if it's a little bit larger, like pigeon eyes. It's been described as looking like pigeon eyes. At this point, when you can see the deposit of hemosiderin and detect the presence of endometriosis, you then can make the diagnosis that it exists. Prior to then, as I said, it is invisible and you won't see it. So with the presence of these deposits, the normal lubrication of the pelvic organs through the secretions is disrupted. And now it is possible for organs to stick against the pelvic wall, against the ovaries, for the tubes to be gummed down. And at this point, you have adhesions that can form because of the endometriosis. Until quite recently, the only way to really diagnose endometriosis definitively was by seeing these deposits in the pelvis. And this required surgery to open the pelvis, either through an incision made for some other reason and you'd coincidentally find the deposits, or through laparoscopy, where a telescope-like instrument is passed through the belly button and you look in the pelvis and you will see these deposits directly. This, even today, affords the only absolutely definitive method for diagnosing endometriosis. But quite recently, Young and Lessie, two researchers, discovered that women who have early endometriosis and late endometriosis, and perhaps even before the endometriosis becomes overtly manifest by these pigmented lesions, have an irritation or a kind of chemical inflammation of the endometrial lining. And if you do a biopsy of the uterus and test that biopsy for a certain protein called BCL6, which is B cell lymphoma protein 6. The presence of this protein in the biopsy material upon staining in a high enough concentration points towards the presence of endometriosis in a high percentage of cases. And that can be as high as 60 or 70% of people that test positive for BCL6. What was very interesting, and we'll talk about this more later, is that in women who were found to have BCL6 present by the so-called Receptiva test, which was released some time back, these women are women who have a markedly reduced chance of getting pregnant through IVF. In fact, it has been shown that the pregnancy rate is as low as 15%, even in young women who test receptiva or BCL6 positive, as compared to 4 times or 3 or 4 times higher in women that do not have it and of similar agents and circumstances regarding their ovarian reserve. There's little doubt that this receptiva test is helpful in having a high suspicion of endometriosis being present, but it by no means diagnoses endometriosis absolutely. Okay, let's go back a little bit. When these deposits of endometriosis are present on the ovary or on other surrounding organs, they can become confluent. And as they become confluent, that means they merge together, the lesions enlarge in size. If it's on the ovary, there can be bleeding into the lesion itself, which can then form a cystic structure we call an endometrioma, or a chocolate cyst, because the blood that occurs inside of the cyst has the appearance of molten chocolate. These endometriomas can also interfere with fertility because they irritate the connective tissue in the ovary to make it produce excess amounts of the hormone testosterone. And if there's too much ovarian connective tissue testosterone production, it can get into the follicles in that ovary and it can compromise egg development and result in a much greater likelihood that the eggs will be chromosomally abnormal upon extrusion, resulting in abnormal aneuploid embryos with reduced chance of success. In the early stages of endometriosis, we only have the small little pigeon eyes or isolated gunpowder burns from the endometriosis present. As it progresses from the mild to the moderate variety, some adhesions form because pelvic structures adhere to one another for the reasons I gave earlier. Then it goes to the next stage where it forms these chocolate cysts in the ovary. We call that advanced or moderately severe and moderately advanced endometriosis. And then it spreads from there and becomes severe endometriosis when this is further compromised by adhesion formation and damage to the fallopian tubes and surrounding structures. That's the genesis of endometriosis. However, what is interesting and what makes me believe in this theory of retrograde menstruation and an immunologic cause for endometriosis is the fact that women who have endometriosis often have an immunologic implantation problem in the uterus. We were able to find that about 50 to 60% of women who have endometriosis also have autoantibodies known as antiphospholipid antibodies in their blood. And these antibodies occur because of an immunologic reaction where the body reacts to its own tissues. We also know that 1/3 of women with endometriosis have an increased activation of immune cells in the uterus called natural killer cells. These natural killer cells are large lymphocytes that journey from the bone marrow into the uterine lining and reach there every month, where they multiply under the effect of estrogen in the early part of the cycle. The natural killer cells, so that you should know, are good guys. Under normal circumstances, all women have natural killer cells in their uterine lining. In fact, they comprise 70% of all the immune cells in the uterus. And their role is to regulate the normal implantation process, where the roots of the embryo grow into the wall of the uterus to form the placenta. But in 1/3 of women who've got endometriosis, and here it's important to know, regardless of its severity, and even before it is visible when you do a laparoscopy and see it, 33% of women who have endometriosis will have these natural killer cells activated or toxic. So what makes them toxic? To understand that, you have to realize that normally natural killer cells release growth factors we call cytokines, of which there are two varieties, type 1 and type 2, or Th1 and Th2. The Th2 cytokines attract the roots into the wall of the uterus to form the placenta. And without that happening, without the placenta, there's no lifeline for the baby. So you've got to have Th2 cytokines. The Th1 cytokines are called cellular cytokines, and they release certain types of cytokines known primarily as TNF-alpha and interferon gamma. And what these do is they cause the cells of the roots of the embryo to go into a suicide mode and die off. So they trim down and cull down the roots of the embryo to create a balance, so that while the Th2 attracts the roots into the uterus, the Th1 culls them down to create a balance, a homeostatic equilibrium, so that the placenta as it develops will grow in an orderly fashion, not grow through the wall of the uterus like a cancer. And when the baby's born, the placenta, because it's confined to the inner aspect of the uterus, will come away easily. This is absolutely essential for normal, viable pregnancy to occur. So you've got to have a balance between Th1 and Th2, and when the natural killer cells are activated, such as occurs with endometriosis and other autoimmune conditions, such as lupus erythematosus, rheumatoid arthritis, lupus erythematosus, rheumatoid arthritis, and scleroderma, and hypothyroidism is another one, then in those situations, the natural killer cells often become activated, overproducing Th1 cytokines, which kill off the roots of the embryo, so that the woman can lose the pregnancy before she knew she was pregnant in the first place. Thinking she's infertile, she's really having early mini miscarriages so early she never knew she was pregnant. Or it will damage the roots of the embryo, and the embryo will limp along until it is lost through a miscarriage. This can occur very early on, before you can even see the pregnancy by ultrasound, and then we refer to it as a chemical pregnancy or a very early loss, or it can go on and result in a loss in the first 10 or 12 weeks of pregnancy. This is why with endometriosis we see an increased incidence of repeated miscarriages, and we also see, of course, a much higher incidence of infertility. It is important to understand that endometriosis is so common that it is one of the commonest causes, as I said earlier, of unexplained infertility, and one of the commonest causes of repeated miscarriages, and that it is one of the commonest causes of chronic pelvic pain in women of the reproductive age. Now, it takes time for these deposits to develop and grow and spread in the pelvis. And that is why the younger the woman, the less likely it is that endometriosis will be present. And endometriosis is most commonly seen in women in the second half of their reproductive lifespan, in their late 20s and in their 30s. But it can also occur earlier. It can be pretty virulent, and it can spread pretty fast. So you need to know that endometriosis is far less likely in a young woman with infertility than it is in an older woman, especially if the woman is symptomatic. It can be non-symptomatic altogether, but when it occurs in women who've got pelvic pain associated with periods, pain associated with deep penetration during intercourse, and pain associated with ovulation, and that woman also has heavy bleeding, then the chance that this is endometriosis is very high, well over 70%. So in any woman who presents to me with severe heavy bleeding, or that is bleeding that's prolonged, that is painful, and associated with painful intercourse and ovulation. Top of the list of my suspicions is endometriosis. In those women, if you do the receptiva test, you're going to find that roughly 60-70% of them will test positive. So, what causes the infertility with endometriosis? Well, here's the reasons. First, let's go back to these small lesions in the pelvis that develop all over the pelvis. They are present there even before you can really see the pigmented gunpowder burns or pigeon eyes. These lesions release toxins into the pelvic cavity. Now here the egg comes from the ovary, and in the early stage of endometriosis the egg is usually normal because there's not yet any ovarian lesions present and it hasn't spread all over the pelvis, so it's a normal egg that leaves the ovary. It has to cross over the environment of the pelvic secretions through a river of toxins to reach the tube where it's going to fertilize the egg. And en route through these river of toxins, it's like trying to swim across a river full of piranha fish or alligators. You may reach the other side of the other bank, but you're less likely to come out there intact and far less likely to be able to make it a journey into the interior. The same it is with the egg. It crosses over through this environment, leaving the ovary normal, being damaged en route through the toxic environment to reach the tube, and now its ability to be fertilized by the sperm is 4 to 6 times lower. Why? Because these toxins damage the envelopment of the egg, the little shell around the egg, and of course the egg looks like a chicken egg, only it's the size of a grain of sand. So these sperm cannot get through the shell of the egg because the receptors on the surface of the egg for the sperm, known as ZP receptors, are compromised by these toxins. So now the egg can't fertilize easily, and the chance of the woman getting pregnant is reduced. It is not zero. Endometriosis doesn't cause sterility. It reduces the chance of the woman getting pregnant over time. And this is called reduced fecundity, not reduced or not sterility. And that is why some women with endometriosis actually get pregnant. And then when they try to get pregnant again, they face the same hurdle, and it's more difficult, which is one of the reasons that endometriosis is one of the commonest reasons for a woman having a baby and then failing to get pregnant again afterwards, or miscarrying repeatedly afterwards. So for that reason, when a woman presents with only having had one baby and then not being able to get pregnant again for many years of trying, and especially if she had difficulty getting pregnant the first time for the first baby, you have to suspect endometriosis as a common cause and evaluate for it. So this is one of the commonest causes of endometriosis, causing reduced fertility or reduced fecundity. It is important to keep this in mind when you are treating women who come to you with unexplained infertility or secondary infertility, meaning they were able to get pregnant once, but they couldn't get pregnant again easily after that. The second reason for infertility with endometriosis is what I told you earlier on. The lesions increase, they then spread, and then you get pelvic organs, including the fallopian tubes, adhering to surrounding structures, so they can't move freely and they can't pick up the egg easily. It's interesting. Most women with endometriosis will have open tubes because it attacks the tube from the outside, not like pelvic inflammation with gonorrhea and chlamydia, where it damages the tube starting on the inside and therefore damages the very sophisticated inner lining of the tube. With endometriosis, the problem starts from the outside. And the last thing to happen is the tube closes and then it's blocked. But it can happen. So when you get scarring of the tubes, they can't move around freely to pick up the egg off the ovary, you will have reduced fertility due to organic causes, due to anatomical disfigurement caused by more advanced endometriosis. And then the third reason I gave you earlier was that there can be endometriomas in the ovaries. There's, of course, some controversy surrounding to what extent these endometriomas affect fertility. But in 38 years of being involved in the IVF arena, I can tell you that if you have an ovary with an endometrioma of more than 1 to 1.5 centimeters in size, very often the eggs derived from that ovary will be of a much poorer quality and will not produce healthy, competent embryos upon fertilization. So in my experience, and I tell this to all my patients, if you have an endometrioma in the ovary, no matter what anyone tells you, don't go ahead with IVF until you've actually had that endometrioma removed. Now, how do you get rid of endometriomas if they're present? The traditional way is to do a procedure called laparoscopy. And here you go in with a telescope, you find the endometrioma, and then you remove the cystic structure completely through excision, or you laser the entire lining of that endometrioma away. If you just drain it by sucking out the chocolate fluid, it will come back. It will come back. Because the lining is endometrial tissue, and as you menstruate, you'll bleed through that lining into the cystic cavity again, and it will build up over time. It's important, therefore, to completely remove that endometrial lining of the inner wall of the cyst so that it doesn't recur. And as I said, this is done through ablation, where you actually cauterize or laser away that lining completely, or you excise the entire lining from the cyst, and then it won't come back again. But there's another way to get rid of it that doesn't require this degree of surgery. It's less expensive to do. It's equally effective. In fact, I believe more effective. And we were the first to describe this about 15 years ago. And that is a procedure called sclerotherapy. You do an ultrasound with a woman asleep. You put a needle into the pelvic cavity and you infuse about 2 liters of fluid, 200 to 400 cc's of sterile saline solution into the pelvis. So it's there, you've caused what we call hydroflotation. You've introduced fluid into the pelvis. Then once you've done that, you put a needle into the endometrioma and you flush out all of its content. It's a slow process because the stuff is thick like syrup. So you suck out a little bit, you inject a bit of fluid, dilute it, suck it out carefully till you've emptied out the endometrioma. And then what you do is you inject 5% tetracycline hydrochloride into the cavity that you've left empty, and then remove the needle. Once you've done that, you then aspirate the fluid left in the pelvis. The reason for putting that fluid is to avoid the tetracycline from getting into the pelvic cavity and causing irritation and possibly adhesions and scar formation. So this procedure of sclerotherapy is something I always reserve for people doing IVF, where they need IVF, and therefore if a few little adhesions form in the pelvis, it's not going to cause a lot of damage. I wouldn't do it for women who've got endometriosis, choosing to wait or choosing to use other forms of treatment for fear of scar tissue. The other problem is if you don't put that fluid in the pelvis and then suck it out afterwards with any amount of the tetracycline solution that might have spilled into the fluid of the pelvis, this will cause a lot of pelvic pain that will be present for hours afterwards. If you do this correctly, it's painless. The woman can go home straight away and return to normal activity without any fear whatsoever. In my opinion, in summary, endometriomas need to be addressed before you do IVF. Otherwise, the eggs removed from the ovary affected by the endometrioma will always be of poorer quality. If the other ovary is not affected, then of course that's fine. You can remove eggs from that ovary, knowing that the eggs you remove from the ovary with the endometriomas in it will be compromised. We ran a brief study looking at women who had endometriomas only on one ovary and not the other, comparing the eggs that came out of the one ovary versus the other, and there was a demonstrable difference in the quality of those eggs and the embryos they produced, and the chance of pregnancy resulting from the transfer of embryos that resulted from the fertilization of the eggs from the unaffected ovary. Now, there's a final factor that is extremely important, and it centers again around my thesis that endometriosis has a major immunologic component. And that is that, as I said, a third of women with endometriosis have activated natural killer cells, and 50 to 60% of them have antiphospholipid antibodies. Women who've got activated natural killer cells with endometriosis will not conceive easily if you transfer embryos to the uterus without addressing this activation. And this used to be treated through the infusion of a substance called intravenous gamma globulin into the bloodstream, 10 to 14 days before embryo transfer, and combining it with steroid like dexamethasone, prednisolone, or prednisone. And the intravenous gamma globulin that you infused had the effect of regulating and rebalancing the Th1 and Th2 cytokines. And now if you transferred the embryo and you had a balance of the Th1, Th2 cytokines, now you would have the same chance of conceiving as if you never had the problem in the first place. The alternative to IVIG, which is a blood product, and no one likes to receive infusions of blood product in this day and age of hepatitis B and HIV, is the fact that it is very expensive, can cost upwards of $3,500 for one infusion. That's about a third of the cost of an IVF. And the fact that there are side effects that are quite severe in some women that need to be watched for and carefully monitored. The use of intravenous gamma globulin is effective. And we've helped thousands of women achieve pregnancies through gamma globulin infusion. I think especially of a woman from Australia that came to see me some years back after 23 recurrent IVF failures, who was treated with intravenous gamma globulin by me, and at the age of 42 with very severely diminished ovarian reserve. In fact, she was almost premenopausal. I got 3 eggs out of her, transferred the embryos with IVIG coverage, and she had a baby that same year. But we don't have to use IVIG any longer. There's a new approach where we use a substance called intralipid. It's a synthetic, harmless, in most cases, substance that costs about 25 times less than IVIG, and it's infused 10 to 14 days before the embryo reaches the uterus, combined with dexamethasone, which is what we use, the steroid we use. And when the woman has a positive pregnancy test, she gets one more infusion, and then the process is over and she doesn't ever need any more. And her chance of getting pregnant is multiple times greater than without this treatment. Using intralipid and steroids in women with endometriosis who've got activated natural killer cells, and adding Lovenox, which is a heparin-like substance, if she's also got antiphospholipid antibodies, virtually eliminates the immunologic consequence and jeopardy caused by endometriosis in a third of women that have this condition. It therefore is, in my opinion, mandatory, essential, that all women who are suspected of having endometriosis undergo blood testing for natural killer cell activation and antiphospholipid antibodies. And there are only 3 or 4 places in the United States that can do this adequately. You cannot send the blood to your regular local reference laboratory. They can't do the tests with sufficient sensitivity and specificity. I send my patients' blood to a place called ReproSource in Boston, Massachusetts, where they do the tests, and 12 days later they give us the results. And if the woman tests positive for natural killer cells, it doesn't really matter whether she's got unrecognizable endometriosis in the very early stages or a more advanced endometriosis. The treatment is the same. Intralipid infusion, 20% intralipid infusion, and done slowly over a few hours, 10 to 14 days prior to the embryo being transferred. You only need it before the transfer. Therefore, women having embryos banked don't need it in the harvesting cycle. They only need it with a frozen embryo transfer cycle that follows. And very often in these women, especially if they're older, I will combine this process with doing PGS, pre-implantation genetic screening, also known as PGT for aneuploidy, PGTA, in order to make sure that the embryos we're putting back are chromosomally normal, in order to cover that side of the equation and improve the chances of pregnancy. We were the first to introduce PGTA into the field of IVF back in for full chromosomal assessment in preparation for IVF in about 2004, 2005. Proudly, this has resulted in a big breakthrough, and it's now used throughout the world in almost 4,000 IVF centers. We've had many babies born, and this is especially indicated in women who've got other problems, such as recurrent IVF failure, such as unexplained infertility, older women, women with recurrent pregnancy loss, and women with endometriosis. To help even improve the results even greater by putting a good seed, namely a competent embryo or blastocyst, into a receptive uterus that was rendered receptive by using intralipid and steroid therapy as I've just described. So to close this all off, let me give you a little synopsis. Because women with endometriosis are not always sterile or not always infertile and can have a baby, IVF is not absolutely required for all women with endometriosis unless it's more advanced endometriosis with significant adhesions, endometriomas, and spread within the pelvis. And unless the woman is older, and why do I say that? If the woman is over the age of 35, her chance of getting pregnant on her own or through procedures where we do things like intrauterine inseminations is reduced dramatically because her egg quality declines with age as well. And in women in their early 30s, 1 in 2 or 2 in 3 of their eggs are going to be normal. Whereas in women over 35, it's only 1 in 3 or 4. Women of 40, it's only 1 in 5. Women of 42, it's only 1 in 12. And women of 45, the chance is probably no better than 1 out of every 20 eggs being normal. For that reason, you want to know that the embryo is normal before you put it back. And that requires PGS, PGT, which you can only do if you do IVF. So for younger women who are under 35 and have normal egg production as evidenced by a test called the AMH, anti-Mullerian hormone test for ovarian reserve, you needn't do IVF if they are willing to wait and take the chance that it might not work. Whatever we say here, please know this. Only IVF will improve the chances of pregnancy in any woman with endometriosis because you remove the eggs by needle aspiration before they reach the toxic environment of the pelvic secretions and get compromised by this. You're removing them and fertilizing them outside the body, whereas if the woman ovulates on her own, the egg has to pass through this environment to get to the tube and will be compromised en route. That is why procedures such as intrauterine insemination or the use of fertility drugs in women with endometriosis, no matter how mild it is usually very unlikely to be successful. In fact, it's 5 or 6 times less likely to be successful than if they don't have the problem, and it's far less likely than even that if in addition to this they've also got an immunologic implantation dysfunction or IID caused by natural killer cell activation and phospholipid antibodies. And that is why IUI, in my opinion, is relatively contraindicated in women with endometriosis because the chance of success, instead of being 15 to 20% per cycle, is going to be somewhere in the order of about 4% per cycle. And when the woman is already over 35 and has diminished, and regardless of age, has diminished ovarian reserve with an AMH of under 1.5, in my opinion, IUI or a wait-and-see approach is not acceptable. IVF is the only way to be able to get the egg fertilized safely outside the body, test it by PGT, PGS, and then replacing that embryo into the uterus, giving the best chance of success, provided that if there's an immunologic implantation dysfunction, this is addressed with intralipid and steroids, and when required, also Lovenox in advance of the embryo transfer. Summarizing, women under 35 with normal ovarian reserve can wait and can delay trying IVF because they could get pregnant on their own as long as they've got the time to do so, which means they're young enough and the eggs are therefore of good enough quality and they don't have diminished ovarian reserve with an abnormal AMH. Such women can try, but they should know that if they get pregnant through trying on their own or through procedures such as intrauterine insemination, it more than likely has got nothing to do with what they did, but that they got pregnant in spite of what they did. Whereas with IVF, for the reasons I've given, you can bypass this problem, so at any age, IVF offers a better chance of success by far. But for women over 35 or for women of any age that have diminished ovarian reserve, you need IVF as your prime treatment because you don't have the time to waste. You've got to make hay while the sun shines. This is a synopsis, it's a big subject, of my approach and why I do what I do for women with endometriosis. Now, for any of you that want to talk to me, I advise you to call my assistant Patty Converse at 702-533-2691, 702-533-2691, and set up an online consultation with me to discuss your case. Conversely, you can call her if you're in Canada and the United States at her 800 number, which is 800-780-7437, and she will set you up for that consultation. Patty will immediately forward you a questionnaire that you need to fill in as detailed a fashion as you can for your own sake, and try to get as many records back to me for review before we interact. But if you can't get them, we can always go back to getting those that I need you to go looking for after our initial consultation. You can also make a consultation with me by going directly to my website, shareivf.com, www.shareivf.com. And when you get there, you will find on the home page an invitation to do a consultation with me. And click on that, it'll take you to a form on the second page, which you fill in and click and submit it to Patty, and she will then reach out to you, provided you leave her your home or your cell phone number on that form as well, so she can reach you and then help you get to me through an online consultation. Another way to reach Patty would be to go and email her directly. The email number is concierge, CONCIERGE, at shareivf.com. Concierge, CONCIERGE, at shareivf.com. If you email her, she will get back in touch with you, and in the same route, she will help you access a copy of the questionnaire to fill in, submit it, and I will get to have a consultation with you. Because of this horrific pandemic we're going through with coronavirus, I have a backlog of patients that are really trying to get in to consult with me. So, and whom I have to back up to get into cycle, because we had a lot of people prefer not to come to me in Los Angeles for treatment because of Corona. And now with it opening up a little bit, we're opening up our cycles, and in November I expect to have a very busy cycle. So that for those of you that want me to help you, I urgently suggest that you contact us as soon as possible, so at least you can get in line to have treatment done, if needed, with me down the line. We also have a Sheer Fertility Solution Center in Manhattan, New York, run by Dr. Drew Tortoriello, who's worked with me for a decade. We work very similarly, very closely together. We interact and consult with each other on all the patients I send there. So that for those of you that live on the East Coast and don't want to travel to Los Angeles to be treated hands-on by me, but would like my input and my recommendation for treatment transferred to New York for Dr. Tortoriello to implement, for those of you that wish to do that, New York is a good option. If you need or want me personally to do your IVF at the present time, I'm only doing IVF in Los Angeles 4 times a year, and my next cycle is coming up pretty soon. So I urge you to contact us as quickly as possible if you want to get in. Thank you very, very much for your attention. Please stay safe.